Hello everyone, how are you today? So what'd you think of that piano music when you came in? Great, right? Yes, if you see her on the way, tell her thank you, come more often. I think she said she's scheduled for next Monday too, so exciting. We're starting to get more and more piano players. If you know of people that like to play, have them call me because we would love to fill Mondays and Thursdays from I would say 9:30, 10 in the morning until about 3 in the afternoon. We would love to find more people. I have some people say, well, Kim, I only know how to play hymns from church, because they've been like the piano player at their church. That's fine. Music's music. So we would love to have more piano players. So I am super excited to introduce Dr. Hess. He's going to be speaking a little bit today on sleep apnea's role in your daily health. So it's one of those things where you think you kind of have it or you're ignoring it. He's going to tell you a little bit more about it. So welcome.
We'll see if I need this. Can you hear me okay?
Yeah.
All right. As Kim said, I'm Dr. Benjamin Hess. I'm a family practice doctor here in Astera. I've been practicing about 15 years here. And I am going to talk about sleep apnea. When you think about it, we spend roughly a quarter to a third of our lives sleeping, and I don't think we always appreciate how important that part of our life really is to our overall health. So we'll kind of cover some bases on that. First of all, though, what is normal sleep? So there are 4 stages of our normal sleep. It starts out with light sleep, deeper light sleep, deep sleep, and REM, rapid eye movement sleep. Briefly, the light sleep is often the stage of sleep that you might not even realize you're in. If anyone's ever woke you up and said, oh, you were snoring, and you said, no, I wasn't even asleep yet, you probably were in the light sleep. Your brain hadn't fully shut off yet. And then each of these stages is a transition, and we cycle through these stages about every 90 minutes. You go through this about 4 to 6 times per night. I've got another graph coming up next, so I'll kind of highlight the details here a little bit more. But there's a couple of things to realize, key points here. The REM sleep gradually gets longer and longer as the night goes on. And that's the part that is mentally restoring. So the deep light sleep is the physically restoring part of sleep. So if you don't get into the REM sleep, your brain doesn't feel like it's actually rested at all. And for someone who has trouble with sleep apnea, that might be what you're noticing. So this kind of demonstrates how the normal sleep cycle works. You can see that you go to bed around 10 p.m. There's a brief period of time where you're falling asleep, that light sleep. And then you cycle through each of the stages, and you can kind of see as time goes on that the dark blue line gets thicker and thicker as the night goes on. Your brain is getting more and more rest as that happens. And by late morning, 4 to 6 a.m., you're having the longest portions of your REM sleep. So what exactly is obstructive sleep apnea? This is the disruption of your normal sleep cycle due to collapse of your upper airway. And you can kind of see basically the front of your jaw, your tongue, your neck muscles can all relax to the point that they fall against the back of your airway, completely block it at times. That leads to snoring, that leads to gasping for air, that leads to low oxygen levels, choking feelings, your body does all kinds of things involuntarily to try to open that airway up and restore the oxygen to your brain. Typically, people that are having sleep apnea spells will have 30 to 60 of them an hour. So that means roughly every minute or two you're having a spell where your oxygen levels are dropping. How common is sleep apnea? Well, it's slightly more common in men, but it still affects 15 to 30% of the men and 10 to 15% of women. And so with those statistics in mind, it's estimated that 936 million people worldwide have sleep apnea in kind of the, just the basic criteria, which is the 5 events per hour. That's almost 1 billion people. And half of those have moderate to severe sleep apnea. And we're just talking in the age range 30 to 69. Incredibly common, probably one of the most common conditions out there, really. What are some of the more common signs and symptoms? Probably some of the obvious ones: daytime sleepiness, not fatigue, sleepiness. Fatigue can mean a lot of different things, but the sleepiness is typically what we're talking about. You'll have non-restorative sleep. That means you wake up in the morning and you feel like you didn't sleep at all. It doesn't matter how many hours you've been in bed and how many hours your eyes were closed, you wake up and you don't feel like you slept awake. The already mentioned snoring, gasping for air, pauses in breathing. Oftentimes whoever's in the bedroom with you will report this. You might even wake yourself up with this gasping or choking episode. A less commonly known one is restless legs. So if you're somebody who struggles with restless legs, that can be a sign that your body is not relaxing well at night, might not be getting enough oxygen. That could be a cause or a side effect of the sleep apnea, I should say. And paradoxically, insomnia is another possibility here. So at some point, your brain gets so focused on the trouble it's having sleeping and it knows that it's losing oxygen, and it subconsciously can keep you awake and prevent you from falling asleep. During the daytime, then, this leads to concentration problems, cognition problems. Your thinking is slowed, your ability to maintain your concentration is slowed. It affects your mood. People get irritable, and this gradually gets worse over time. I've had patients that have thought they were developing dementia. We treat their sleep apnea, and suddenly they're a brand new person. Another common one is waking up with headaches. So it might not be your pillow, it might be lack of oxygen all night long that's causing your headaches in the morning. And then some people get very vivid or strange dreams. So if your dreams have changed in the last few years and they seem to be different than they used to be, that might be the underlying cause. And then I kind of highlighted that last one, frequent nocturia. That means you're getting up a lot at night to go to the bathroom. And I tend to have a lot of men in my practice, and they often come to me thinking they have a bladder or prostate problem, and what we end up finding out is they actually have sleep apnea, and their brain is not relaxing enough, and so then they don't get into deep sleep, so they're always feeling the urge to go to the bathroom, so they just get up and go so they can go back to sleep, which they never actually do. So that's another common symptom, actually. What are your risk factors? Older age, male, obesity. Older age happens to be mostly due to tissue strength and integrity, which is similar for the obesity. So anything that makes your neck muscles, your skin, your other tissue relax more can cause this to happen over time. Any facial, neck, mouth, jaw abnormalities can cause problems. So if you've had dental problems, jaw fractures can sometimes lead to sleep apnea. If you have large tonsils that were never removed, if you have a goiter, thyromegaly, that can be a cause. If you're a nose breather and you have a lot of nasal obstructions, that can cause problems too. Deviated septums, for instance. Smoking and alcohol use also can contribute to this. So the smoking kind of damages your airway and also can affect the tissue strength. And then the alcohol sedates you and makes you feel tired, but it doesn't let your brain relax and cycle through the proper steps in order to fall asleep well. And then there are many medications that have side effects that can affect your sleep. So some of the actual medicines prescribed for insomnia, common ones out there like Ambien, for instance, they don't always help your brain get into the natural state of sleep. And so that can lead you to some sleep apnea problems. Some anxiety medicines, and we're talking about things like Ativan, Klonopin are some common ones, Xanax. Those can also trigger and worsen sleep apnea. Same with some of the opioid pain medications. So we're talking things like hydrocodone, tramadol, Percocet, and those two interact very badly as well. So the combination of those anti-anxiety medicines I mentioned and those pain pills can also significantly increase your risk of sleep apnea. In fact, when we talk about drug overdoses, that's the most common cause of death for those patients. Any other sedating medications can also lead to this, but I did want to call out specifically things like Benadryl and Tylenol PM. That's a common thing that people like to use to help them sleep better at night. And both Benadryl and Tylenol PM has Benadryl in it. Those two medications do not work well when you're over the age of 65. They've been shown over time to cause cognition changes, balance problems, increase your risk of falls. Some people develop dementia-like symptoms when they're using those medications. So if you're over the age of 65, I would caution you in using Benadryl on a regular basis. All right, so let's say you have sleep apnea and you don't do anything about it. What happens? It's a common trigger for high blood pressure. You can develop the memory problems and the mood disorders we talked about. It leads to accidents, motor vehicle accidents. The stress that comes to the body increases your chance of developing diabetes, leads to increased weight gain. It gets to be a vicious cycle. The more weight you gain, the worse your sleep apnea gets. The worse your sleep apnea gets, the more trouble you have with weight gain. It leads to a lot of heart conditions. Atrial fibrillation can be triggered by this or worsened by this. Congestive heart failure can be a factor here. You can get the long periods of low oxygen levels can lead to congestive heart failure. And then heart attacks. And we've kind of known for a long time that the vast majority of heart attacks seem to happen in the middle of the night. And anecdotally, I know this from working in the ER in the past, that we saw most of our patients coming in somewhere between about 3 and 6 a.m. with their chest symptoms that were the true heart attacks. And I think what we've realized now is that a lot of those patients had undiagnosed sleep apnea, and the stress overnight led to enough of a problem that eventually tips their heart over the edge and triggers their heart attack for them. So if you look at that first slide I showed you with the graphs, you can see that the deepest part of the sleep is typically when the heart attack showed up the most often. So how do we figure this out? A real easy thing you can do is this screening questionnaire called the Epworth Sleepiness Scale. And I'll actually present you the questions at the end. You can kind of go through it if you want and see where you score. That's really just a screening test. It's not a diagnostic test. There's lots of things that can cause that to be high, but if you score really high on that, you might want to talk to your doctor about why you're not sleeping well. There are a lot of patients that will do a home oxygen overnight test. So basically you just get a little device you wear on your hand. It's like the oxygen sensors you might have worn in the clinic or the hospital. And it'll just record your oxygen levels throughout the entire night. And we'll be able to see just on there if you have dips and how often they happen, how long they are. And that can lead us to doing a sleep study in an actual lab. The overnight oxygen tests are probably not clearly definitive either, but if you score positive on that, you probably have something going on in your sleep that needs to be figured out and taken care of. And then the overnight sleep studies are the gold standard. So you get hooked up to a bunch of wires, more than you can imagine, and we watch you sleep all night long. And we can tell when you're sleeping. When you're hooked up to these sensors, we can tell when your brain is actually in the REM sleep and when you're in the actual sleep, when your brain waves change. So it's a true diagnostic test. And then a lot of them do a split night test, which means that if they identify that you have sleep apnea, they spend the rest of the night trying the different masks and pressure settings to kind of get you comfortable where you're breathing correctly and getting the problem fixed. So I've got an example of some of these masks that you might see. And everyone's different, and there's a lot of different styles of masks and machines now. Some people are mouth breathers, some people are nose breathers, some people need both. Some people have too much facial hair and the masks don't fit very well, so we gotta work with that. It might depend on if you're a side sleeper or a back sleeper or a front sleeper. So there's lots of different varieties. There's lots of different settings they can do on the machines. The newer machines adapt to your needs, so they will do what's called auto titration. So they'll increase and decrease the pressure, breath to breath, hour to hour, depending on your needs. They're typically just blowing humidified air. Sometimes you might need oxygen attached to it as well, so they can do that as also. That's the most common kind. The basic things you can do is just simple lifestyle changes. Weight loss, avoiding alcohol, avoiding those sedating medications we were talking about. Those can all sometimes correct mild or minor sleep apnea symptoms. But the CPAP by far is the most commonly used one. You can get dental implants as well that can sometimes help protrude your jaw out and pull it forward. They work for some people, but I would say they're not as successful. And they take a lot of getting used to. Usually people complain of they'll have jaw pain, they'll have mouth pain from them, you might drool a lot. They don't always solve the problem, but there's certainly something you can try, and a lot of the time you go to your dentist office to explore that with them. There are several different options on the surgery side. You can do something called a uvulectomy, so that little hanging ball at the back of your throat. You can remove that and a lot of the soft palate attached to it and open up that airway more. Yep, that's just as fun as that sounds. You can do some implanted devices, and those will use an electronic signal. You'll turn it on with a little external device. Usually there's an implant under your chest or near your neck, and you rub the magnet over it, turns the device on before you go to bed, and it stimulates the muscles all night long so that they hold your jaw in the proper place. So some people really like them, especially if they've done poorly with the CPAP. I think the biggest problem there is that it's a surgical device. You got an implanted device in your body. There's a surgical risk of installing it and the complications that come from that. You got to find a surgeon that's able to do it, willing to do it. You got to find insurance willing to pay for that procedure. And for the most part, it's a little bit of a cost risk analysis there. Not everyone's a good surgical candidate. And then lastly, if all this fails, some people end up going with a sleeping medication or just using oxygen, plain old oxygen at night, especially if you're claustrophobic and you don't tolerate the CPAP and you're not a good surgical candidate, you might end up with that. That may help you a little bit, that may help mitigate some of the risk, but it doesn't completely correct it. And so it's usually our last case option for people. It's not the best case. I got a photo here of some of the devices that you can get implanted. So they kind of sit underneath your jaw and your neck area, and they stimulate some of the hyoid muscles there and hold your jaw in place all night long. You can see a picture of the uvulectomy. So you get rid of your tonsils, you take a large portion of your soft palate and uvula out, and you have a much bigger opening there. You know, those often leave scar tissue behind. Sometimes you have pain issues related to it. So those are some of the surgical options. We don't have anybody at Astera that does these surgeries locally. There are some options nearby. I think some of the surgeons in Brainerd and St. Cloud do these procedures, Fargo. But it's usually a process to go through. So then I'll show you the Epworth sleep score. So if you have a pen and paper, and you want to take take this quiz here. The way this works is you look at each question, and you have to think to yourself, what are your chances of falling asleep in each situation? And your scale is 0 to 3. 0 is I would never fall asleep in that situation. 3 is I would always fall asleep in that situation. 1 would be a slight chance, 2 would be a moderate chance. So if you're sitting and reading, what is your chance of falling asleep? If you're watching television, what is your chance of falling asleep? Sitting inactive in a public place like a church, a meeting, a bite-sized conversation, what are your chances of falling asleep? Sitting in a car as a passenger for at least an hour, how often do you fall asleep? If you lie down to take a nap in the afternoon, what's your chance of falling asleep? If you're just sitting and talking with somebody, if you ever started dozing off mid-conversation with somebody, that might be a sign you're not getting good sleep. If you are sitting down after a meal, especially if you haven't had any alcohol, it's just a regular meal, do you tend to doze off or drift to sleep after that? And it doesn't have to be after Thanksgiving, it would be on a consistent basis here. Or even driving in a car, stop for just a few minutes. We're thinking like at a railroad tracks, a long stoplight in traffic. So if you score 11 or higher on this, you have excessive sleepiness. And you are not getting good rest at night for some reason, and you may want to explore that more with your doctor. Like I said earlier though, that doesn't guarantee that you have sleep apnea. You may have some other problem going on, but you probably want to find out why you're not sleeping well. And I think that's all I have, other than questions. So I'll start there. If you have any questions for me? Oh, yeah.
So what about the medication, melatonin? Does the pros and cons, does that affect, does that help sleep apnea or not?
It probably doesn't have any effect on sleep apnea. If you have to take a sleeping pill, that's probably the best sleep aid option. Melatonin is a hormone your body makes normally. So you're really just giving yourself a little higher dose. So I would be fine with people using melatonin if that's all you need to help you fall asleep. Probably the best for that. Sometimes it helps you maintain sleep a little bit. But if you don't wake up feeling rested the next day, that's not the only problem. And some people have trouble with higher doses of melatonin, so typically the doses start around 3 milligrams up to about 9 or 10 milligrams over the counter. When you're on about 5 to 10 milligrams of melatonin, usually you start having some pretty interesting dreams. So not everybody sleeps well on those higher doses. So, but that would be probably the only sleep aid I would say is worth trying on your own. Good question. Yeah.
So I've always wondered on like the sleep studies, how do you get an accurate reading when I know if I went in, I know people are watching me, you've got all these wires in your work, how do you even sleep? Right. Like a normal sleep? Yeah.
It's a good question. It's a common question. I can tell you people that actually have sleep apnea and aren't sleeping well have no trouble falling asleep. They're already so sleep deprived that it's very easy for them to fall asleep. They just don't get into the deepest sleep that they need to. So yeah, it seems strange, but you probably don't have sleep apnea if that seems like that would be a tough thing for you.
Well, my score was 3 or 4, so I probably don't.
Sure. Also a good question.
What can you say about central sleep apnea?
That's a good question too. Central sleep apnea is a different cause, so that typically means that there's something going on with your brain itself. And the sleep lab that we have here in the hospital is only really set up to explore and test you for obstructive sleep apnea, so physical oxygen desaturation problems. But there are other kinds of sleep apnea. Central sleep apnea is probably the next most common kind. And yeah, your brain isn't shutting down properly for some reason. It's more of an electrical problem in the brain. And those patients actually do need those sleep medications because they need something to trigger their brain to fall into the correct steps of sleep. You typically need to go to a larger sleep lab to get that done. You probably need to see a sleep specialist first. And they typically have slightly different, they don't usually have the gasping airway problems as much as they just don't physically fall asleep. And they probably struggled with it all their lives too. So that's another usually history difference. So they probably had it a long time. Does that answer your questions? Okay. Yeah.
Does it make a difference or if you're a side sleeper or a back sleeper?
As far as what?
Falling asleep? Sleep apnea?
I think some people do find that a sleep position can correct their sleep apnea to a certain degree. So typically the worst position for that would be on your back. That would be the most likely chance to obstruct it. But some people will have sleep apnea no matter what position they're laying in. Or they can correct it for a while laying on their side, and then eventually they still get sleep apnea in that position as well. So it probably just temporarily treats it. It doesn't usually cure it or fix it permanently for people. Yeah.
On that same thing, okay, so I'll go from stomach to side to back, multiple side, is that just moving from one sleep cycle into another, or how do you say that?
I would say the position changes at night are independent of the sleep cycle. Your brain will just kind of reset and have to move periodically, and it does that automatically. But it doesn't necessarily tie to any specific sleep stage.
You haven't mentioned that people can die, but I sang at a funeral once with somebody.
Sure.
About 35,
Yeah.
died in the night.
Right. I think if you had very severe sleep apnea and it wasn't diagnosed, I mean, people's oxygen levels drop pretty low. It's normal to be in the 90s to maybe low 90s, high 80s in your sleep. But if it starts dropping into the 70s, the 60s, and you spend enough time doing that, you can eventually die from something like that. So yeah.
I have a problem with just waking up all the time.
Mhm.
Once an hour, I'm always waking up, and then I have a hard time falling asleep. And I stay awake. I do all the right things. I stay away from sugar, caffeine, screens. I read before I go to bed.
Sure.
The room is cool. I sleep on cotton sheets. I do it all.
Yeah.
But I wake up all the time.
Yeah.
I wake up.
Yeah, frequent awakenings can be a symptom, but there are lots of other things that can do it also, and that's where I'd say, there might be some things to check out with your doctor. Sometimes there are medications that will help you rest throughout the night, especially if it's not sleep apnea. If it's sleep apnea, there's more specific treatments, but it isn't always in that case, so that there could be other reasons, and there might be other things that you can do to help that. Another question.
Are you more prone to sleep apnea if you've had any type of neck or mouth surgeries or traumas?
It could increase your risk, yes. Anything abnormal anatomy-wise, either that you were born with or that happened later in life from an accident, a surgery, definitely can cause that, could trigger that.
And the removal of the uvula, doesn't that change your speech commonly?
It could slightly, I suppose, yeah. It doesn't, how it sounds, how your voice sounds,
Right.
yeah.
I dealt with a person out in Montana with that, with no uvula, and she could not pronounce S's and R's and so forth and so on.
Sure, yeah, and that could be probably a potential complication from that surgery. I wouldn't say it's a universal issue, but it could happen if the wrong amount of tissue was removed or they develop scar tissue afterwards.
She was born that way.
Sure.
without, yeah.
Sure. Anything else? One more.
So you can be like a snorer and still not have sleep apnea, correct?
Correct. The definition of sleep apnea involves, does it affect your oxygen levels? Does it affect your airway? Does it disrupt your sleep? Those would be connected to that. So if you're just a snorer and you feel rested when you wake up in the morning and we do a test and your oxygen levels are fine throughout the night, then you just are really annoying to sleep with. That's all there is to it.